To the BESSI webinar number 1, 2021. And I was just going to alert you to the fact that we will record this because we put these webinars up on the website. Now that you know where you are, I'm briefly going to stop sharing my screen so that you can see who's on the panel. Again, welcome. Thank you for joining us. And we welcome you to the first of 3 webinars that we've put in fairly close succession to talk about a couple of things that are very urgent to us, which we will start today on discussing and giving some more, I guess, some more substance to what we've called the draft BESSI Principles that some of you will have already seen over the past year or so. But the point of these next 3 webinars is really comes from our recognized need to continue to gather ideas, to continue to strengthen our collaboration, and so on. And I want to very briefly give you an introduction to BESSI in case you are new and you're joining us for the first time. So my name is Mareike Schomerus, and I'm one of the people on this slide that gives you an idea of what BESSI is. BESSI, the BESSI collaboration, is the collaboration between behavioral, environmental, social, and systems interventions for pandemic preparedness. And it's really the brainchild of Susan Michi, Jeremy Grimshaw, and Paul Glagio, who are also all on this call. Alongside with, you can also see Jake Crawshaw. And it was last year that Susan and Jeremy and Paul realized that while the pandemic was accelerating at great speed, there was, and the only possibilities to do something about it in the early days in particular were based on behavioral, environmental, social, and systems interventions, there was a striking gap in what was actually being done to find out more about what was going to work, what was specifically going on, with a very, very quick focus on medical interventions. And you will hear more about this in a second. And so out of this very urgent recognized need, which is also really fueled by a very deep understanding that BESSI is only going to work if people from many different academic disciplines start speaking to each other in a very deep and substantive way, the BESSI collaboration was born. And many of you might have been part of some of these webinars that we have since put up to try and frame a research agenda, understand what is really going on in the various BESSI spaces, understand different types of government responses, different usages of evidence from different governments. And so one very interesting part about the BESSI collaboration, and in a way that is a large part of what we're going to do today, is a main argument has always been that there isn't enough attention on funding and research in the BESSI space. And you will hear in a short while more from Paul on really how drastic that insight really is. But one of the interesting things that we are experiencing, and this is also something that we would like to discuss more today with people who are interested in the BESSI collaboration, is really just how hard it is to get understanding, increased understanding from funders, what this agenda really means and what it needs to accomplish. And fairly recently, we've really had a couple of knockbacks on our attempt to get some funding to broaden the collaboration, to underpin it with some of the research that we think is really necessary to do. So we'll talk about that in a little while more. But today, specifically for the webinar, you'll hear a bit more about the so-called BESSI Principles, draft BESSI Principles, and some unpacking of what they really mean, what we think they mean, and what are some of the movements that have been happening in the space. And then we'll conclude the seminar by sharing some further ideas, doing a bit of brainstorming with everyone to get a sense of what people think the BESSI collaboration should try and accomplish and how we might want to do this. So because these webinars are always a little bit weird in the sense they can be quite involved and they can be quite anonymous, I was going to ask you to participate in something that's called a chat wave, and some of you might already be very familiar with this. So a chat wave is when everyone types into the Q&A box, which is obviously at the bottom of your Zoom screen. You can see the Q&A box, and everyone types a question at the same time, and then we all hit send at the same time, which gives a very nice overview of kind of the collective brain space of a group of people. And so I would want to ask you to please open your Q&A box. And also leave it open because we would love to have you participate very actively in the Q&A box by posing questions. And we have Ray Thomas on the call who will be diligently monitoring the Q&A box. But what I would like to know from you right now in the Q&A box is it's just a question really of where you see, from whichever place of the world you're calling into, in whichever field within BESSI you work, what have been some significant developments that you've seen over the past 6 months or so? Or indeed, where do you continue to see really quite significant gaps? Some of the, maybe something similar to the obstacles that we as kind of the core of the BESSI collaborations have run into. And it would be very nice to give a bit of an overview of interesting developments that everyone has seen, but also continued obstacles, new obstacles that you have seen. So I'll give everyone a minute or so to have a think about it, and then I will shout, hit send now, and then we'll see what comes up. Because Kazi Rahman was by far the quickest of all of us, I will tell, please hit send if you have something to write. So vaccinations are very prominent so far with different angles. Okay, lots of answers. Surveys with quantitative tools, but less qualitative and in-depth explorations. Vaccine hesitancy, so some operational issues of quarantining. The interaction between vaccine and other COVID-safe behaviors. Lots of work on vaccine uptake, but very difficult to see how this translates into policy and practice. That's interesting. So there's some progress that Marie reports. Marie, would love to hear where you're from in recognizing the value of behavioral scientists and contributing to the pandemic, or maybe rather in countering it, I hope. Atle is talking about international collaboration in running trials, so that's really good to hear. John is talking about that COVID is a social episode, not a medical one, and most studies are discipline specific. I think that's a really very interesting framing for BESSI, that it's a social episode, not a medical one. And then we have one contribution from Helen on global education policy that recognizes the role of behavior in supporting sporting integrity, but lack of resources and systems. So again, a lack of a connection there. So fantastic. So we see that lots of things are developing. Some things are stalling. Some are issues that are relatively new. Some are issues that have been around for quite some time. So thank you so much. We will hopefully come back to some of these issues over the course of the webinar. And with that, I think without further ado, I can hold some of these thoughts when we have some time later for discussion. But I want to hand over at this point to Paul, who not only will introduce or reintroduce maybe for some of you what the BESSI collaboration draft principles are, but also will then put some more substance into how some of these principles are currently playing out in practice or not. So Paul, over to you.
Okay, thanks, Marika, and for that introduction. Good to see some positives in that Q&A wave as well, and I might come back to a couple of those. The slide that you see up here is the third tab along the BESSI website on the principles, and this is the draft set of 7 principles that we would like funders, researchers, and other stakeholders to be aware of in thinking about how they should approach the BESSI issues during this pandemic, but during future epidemics and pandemics. These are draft principles, but we did go through 2 rounds through the JISC mail list in trying to develop these, and got lots of good suggestions about the range of principles and the wording of them. I'm going to have a little look at some of the way that the principles have been used or not used, but I'm not going to go through all of them, and Jake will supplement that with a couple of the other principles, but we won't go through all 7 tonight. So next slide, please, Marika. So the first principle is that we should ensure that research to develop, evaluate and implement the BESSIs are a key part of the global preparedness and response to COVID-19 and other and future outbreaks. And so one of the things we've been doing is keeping the scorecard that you see on the homepage of the BESSI website, where we compare the number of drug trials that are registered and reported against the number of BESSI trials that have been registered and reported according to the Epistemologist Love database. And I'll say that we actually extend beyond that, but to do a fair comparison, we just stick to the numbers that we find through Epistemologist for those two components. And I'll also point out that according to one of the BESSI principles, there's lots of different types of research that we need. We certainly need the qualitative research, we need surveys, observational studies. And so we're just using the trials as one easy way because trials are registered. That's a simple way of doing a comparison, but certainly we'd want a broader thing as well. So the interesting thing about this is that there's only about 1/100th the amount of BESSI research that's been going on compared with the drug trials. It's just a massive difference for trials at least. And it would be interesting to see that for qualitative research and observational studies as well. Next slide. So on that first principle, we haven't been doing too well. On the last tab of the BESSI website is the research. And one of the things that we have there is the database of BESSI trials, and we've got 39. The reason that we've got 39 and not just the 12 from the Epistemologist database is that we look in other places. And also people on the, particularly on the JISC mail list, have alerted us to other trials. And there's an incredible variety, some of them not even registered anywhere, that we've been alerted to. So we collect all of the things that we would count as BESSI trials within that database. And so just breaking them down briefly, we've got 11 mask trials as being the most popular single thing. The behavioural thing, we've got a lot on personal protective behaviour and community behaviours, so 17 in total. So that's around half of them are being on the B part of things. We've got a few on the safe settings, which I'd count as the E part of BESSI. And the systems part of it is probably the most neglected. We've got 2 that are looking at messaging in quarantine and 2 on better trials on ways of improving contact tracing. So they've probably been the most neglected of all of the parts of the BESSI, and the B has probably been the most well served. Next slide. One of the other principles is that we need studies to see whether things work, but we also need comparative studies. And to give you a couple of examples of the comparative studies, there's one of the masks ones is comparing N95 masks with a standard surgical mask in healthcare workers. That's a study in Canada and Israel. Second one is testing different procedures to elicit contacts and places. That's one of the 2 contact tracing ones that I mentioned. And then there's an interesting one on messaging, which is got 2 different focuses: don't get it to protect yourself, or don't spread it. Which one is better? And the studies we've seen so far tend to suggest that the social one of don't spread it is actually the more important message to people, the more motivating message. Next slide. So one of the interesting things is we've had one mask study of the randomized trials now give a full report. That was the Dan mask trial, which published last year. But as I said, there are actually 11 mask studies going underway at the moment. The largest single one is a cluster randomized trial occurring in Bangladesh, which has over 64,000 households in the intervention group and 64,000 in the control group. So this is a very large-scale trial. Interestingly, it's been funded by GiveWell via the Effective Altruism Global Health and Development Fund for Innovations for Poverty Action. And it's a notable thing amongst several of the studies that we've identified in that database that the funding sources often seem to be not the usual funders that you would think of. We are currently undertaking an analysis of that and writing to authors to get sources of funding where that is missing, so that we can find out how such studies have been funded. But as I say, this is the largest one. We don't have the results of this study yet. Next slide. But there is a published sub-study. So one of the really clever things, lots of good things about this study, but one of the clever things is that they did sub-randomizations of different things to try and improve uptake. One thing worked, that was seen on the last slide, but most of the things that they tried, like getting all the households to receive texts, an incentive certificate, monetary incentives, public signage, and the type of mask, none of these made any significant difference to the uptake of the masks. But I think that's a very important protocol to have, because it illustrates lots of good features about the way you could do such studies by using a cluster randomized trial, using a very large trial, but also looking at ways to improve adherence as a sub-study of this study as well. So it's one of the better ones in terms of doing comparisons, and I think it's about a third of the studies that we've got in the database so far have some sort of comparison. Next slide. So I was interested in Atlee. Oh, sorry, Nick. Can you just click on Marika? And we should get a little. Yeah, that's it. I was interested in Atlee's comment that he had seen good international collaboration. I think it's probably about the usual rate. So amongst the 39 trials that we can tell from the registration information, we'll get more as we write to the authors to try and find out more. But there are only 3 of the 39 studies that appear to be multi-country. But across all trials, that's probably about the sort of standard rate. So nothing exceptional here, but good to see some international collaboration. Next slide. So these are the multi-country studies, the one I mentioned earlier about the medical versus N95 masks in Canada and Israel. An interesting study on raising COVID awareness in rural communities, a randomized experiment in Bangladesh and India. And I've just shown the Indian results down here. So this is actually in a preprint. The results are fully available. And here they compared different types of messaging, SMS only, a call only, or the combination of them. And you can see that having the call, it was much more effective for the 5 behaviors that they were looking at than just the SMS. And you got a little bit extra by adding the SMS to the call. And the results are similar for Bangladesh, but I just couldn't fit them into the slide. Another interesting one was the short animated video to improve good COVID hygiene practices that started quite early in the pandemic and was being done in 6 countries. And in order to overcome the language problem, the interesting thing they did with the video is to have no words. So the animation illustrates everything. There's a bit of noise and music and grunts and things in the background, but there are no words. So they're actually testing the video for all languages simultaneously to see whether people understand that. Unfortunately, this one's not published yet, but I think it's an interesting illustration of the sorts of innovative things that have been going on within the 39 trials. Next slide. And these are occurring across diverse settings, as well as looking, and this is the 7th principle, of most vulnerable populations. So there's one for disadvantaged, specifically in disadvantaged women, one in nursing homes, and one about income support for poorer or unemployed people, which is great to see. I raised just clarifying that Atlee said that there was too little international collaboration. Yeah, I'd probably agree with that. Next slide. So I'm going to hand over to Jake now, but I think in summary then, several of the principles have been taken up well, and I think the most astounding thing though is just that principle number 1 is the amount or the neglect of BESSI type research generally. So it's the quantity that has been a major problem amongst the 39 that we have. There's actually some quite good quality and interesting stuff that's occurring. I'll hand over to Jake now.
Thanks, Paul. So hi, everyone. I'm Jake Crawshaw. I'm a postdoctoral fellow at the Ottawa Hospital Research Institute with Dr. Jeremy Grimshaw. We're based in Canada. So the work I'm going to speak to is related to the BESSI Principle number 6. So basic development of complex BESSIs on theory-informed specification of target behaviors, structures and processes, and detailed understanding of the barriers and enablers. Now, the context that I'm going to be speaking to about is related to COVID-19 vaccination acceptance and uptake. So I understand this has probably come up a few times already in the Q&A. So this is a real key area in the fight against COVID-19. And the idea behind this work was to take a behavioral science lens to see whether we can use ideas and frameworks for behavioral science to essentially understand some of the barriers and enablers to vaccination acceptance and uptake. So this work is conducted with colleagues at OHRI, I've got colleagues at Brown University, and also in collaboration with COVID-End. So they've got a huge evidence synthesis network that's been going on since the pandemic, and this work was funded by the Public Health Agency of Canada, but I think it's applicable to everybody internationally. And the methods we were using were essentially a living behavioral science evidence synthesis. So the idea behind these living evidence review is because this area is rapidly moving, it's current, knowledge needs to be accumulated, that perhaps a standalone systematic review wasn't necessarily the best way to go, and actually having a living evidence synthesis was the best model to go with. So that really was the rationale behind undertaking some of this work. So linking back to the principle, so theory informed work is obviously central to that principle and central to the work I'm speaking about. So this is the theoretical frame. Sorry, next slide. Thank you. So this is the theoretical frame that is shaping our living evidence syntheses. So you can see here this figure here. It details the COMBI model, so the capability, opportunity, motivation, behavior model, which is Susan's teams developed. So this is essentially 3 core elements that are needed to enact behavior change. And what you can see there under each of those C, O, and the M are the domains from the theoretical domains framework. So these are 14 domains that have been distilled down from decades of research from the behavioral sciences, and these have been mapped onto the domains from the COMBI model. So these were the two models / frameworks that we were using. The idea was to review the existing literature and map on these determinants of behavior change related to vaccine acceptance and eventually uptake. Next slide, please. So the 2 very large ongoing living systematic reviews so far, one's been focused on healthcare workers, vaccine acceptance among healthcare workers. We've also got another one that's focused on the general public. So these updates are, so these searches and the databases are updated monthly. Everything's registered on Prospero. And the main, we're essentially triangulating it over a few different data sources, a few different databases. The main database is run by a colleague at Brown University, Kristen Connew. Essentially, we're doing weekly searches with Medline and the Cochrane Trial Registry, and we're supplementing with other living evidence profiles and rapid reviews that are being conducted by COVID-End. So we're trying to capture as much as we can, but as I say, this is a huge research area. And I'm going to present a few findings, and I'm going to present it from the healthcare worker-focused living evidence synthesis. But just to note that there is also a general public one that I will link, where you can find both these reviews at the end of my slides. Next slide, please. So this is the inclusion and exclusion criteria. So essentially, we were looking for healthcare workers in general. We were particularly focused on individuals from equity-seeking groups. So those are individuals experience racial, ethnic, and socioeconomic disparities and marginalizations. This was a real key point for Public Health Canada. They wanted to see whether different drivers were more pertinent in these groups. Outcome measures, so self-report. We're looking at vaccine willingness and also uptake. And a range of methodologies we were trying to capture in terms of like qualitative data, which Paul alluded to. We're looking for a range of different research methods, cross-sectional, etc. Next slide, please. So to summarize, we've done 2 versions of the healthcare worker focused living systematic review. 64 studies have been included in total, and 32 were added to the latest version, which was version 2. The vast majority of those utilize cross-sectional survey designs. So what we were hoping to see a lot more qualitative work. So hopefully that's being conducted, and we'll see those in future iterations of the review. 16 of 64 studies were conducted in North America, only 6 in Canada, and the rest were spread all across the world. 42 of the 64 were conducted after the vaccine approval point, which was November, early December last year. So the idea to pick that out was to see whether there was any differences in kind of pre-vaccine approval, where there were hypothetical questioning about would you take what would be a hypothetical vaccine versus actually we know something's been developed. What's your intention to go ahead and be vaccinated? So most of the studies included broad healthcare worker samples, but there were specific groups as well, such as nurses, dentists, pediatricians, etc. And 58 out of 64 include data on vaccine acceptance or intention. We only captured 4 of the 64 measured actual vaccine uptake, but we're hoping now that we're further online with vaccine rollout that number will increase in terms of whether we can identify determinants of actual vaccine uptake. And what will be interesting would be to see what are the determinants, whether they differ between determinants of vaccine acceptance and actual uptake. Next slide, please. So this is just a snapshot overall median percentage of vaccine acceptance among healthcare workers pooled across studies. So across 58 studies that provided these data, median percentage was 64% of healthcare workers were willing to be accepted for COVID-19 vaccination. Among North American studies, the median was 58%. So around a half to 2/3 seem to be accepting of a vaccine. Next slide, please. So this is the really the cool aspect here. So this is where we've actually gone back and mapped the determinants based on the theoretical theory/framework that I kind of went over in the first couple of slides. So you can see this figure here. This has the capability, opportunity, motivation, and also the TDF domains listed on the x-axis, and then the study counts on the y-axis. So what we can see here is that 8 of the 14 domains have been captured across at least once across the studies, and the higher bars means the greater frequency. So we can see beliefs around consequences is the most widely represented domain that's been captured in the studies. So that might be concerns about the efficacy, necessity, safety concerns around the virus, around the vaccine, sorry, that you could probably expect that's quite well represented. Another one domain that's quite well represented is social professional role and identity. So the fact that we're looking at healthcare workers, again, there was some studies that found differences in the different occupations. There's quite a strong trend in non-physician healthcare workers. So nursing staff were more likely to have were less likely to be accepted of the COVID-19 vaccine. So that was quite a common finding. Reinforcement, that was a big one. So that was past seasonal influenza vaccination was a really strong and consistent predictor of vaccination acceptance, which again, you might come to expect. And I think what's interesting there is around knowledge. I think knowledge comes up a lot, and highlighting that it's potentially knowledge deficiencies that are really the driver here. But actually, knowledge didn't come up a whole lot. So that may be surprising, and there may be other determinants that are outside of the knowledge sphere that are really important here. Next slide, please. So this is just an excerpt, the snapshot taken from one of the reports that we're producing. So this is the format of how we've essentially synthesized the data from each of the studies. So this was from the TDF domain, environmental context and resources. So essentially we've broken it down into factors associated with lower acceptance and factors associated with higher acceptance for each of the domains. So for example, here, one study found that using Facebook as a main source about anti-COVID vaccination was significantly associated with increased risk of vaccine hesitancy. And we've tried to capture the statistical data where possible. So we've really done a deep dive into the data here. And this is just one such example from one of the domains. Next slide, please. And this, so as I said, only 4 of the 64 studies have looked at vaccine uptake, but what we've done again is to pull those apart from the vaccination acceptance. So this was just one study that looked at, again, that same domain, so environmental context and resources. And one barrier that we found was, that was reported in that study, said common reasons for staff not receiving the vaccine include the staff being off-site during vaccination sessions. So a very practical barrier that restricted some staff members not being able to accept the vaccine, but something that you could probably amend and improve on next time. So again, we're hoping that this determinants of vaccination uptake in future iterations, that this will be more greatly populated. So we're not just looking at vaccination intention, but we're also looking at vaccination uptake as well. Next slide, please. So in terms of equity-seeking groups, so 11 of the 64 studies assessed COVID-19 vaccination acceptance and uptake among certain equity-seeking groups. However, what we were looking for would be for analyses to be based on determinants to be mapped based on ethnicity and race or other equity-seeking factors. And only one study found that, but it was quite a well-done study. And what they found was individual healthcare workers identifying as Black, Latinx, or Asian had a higher likelihood of perceiving distrust in companies making the vaccine, and it was accepted with lower vaccination acceptance compared to individuals, healthcare workers identifying as white. So again, some data, but not enough, and we're looking for more data and more individual or more research that are undertaking this type of work to perhaps think about equity-seeking factors and whether different determinants are more important or amplified in certain equity-seeking groups. Next slide, please. Okay, so that's a whistle-stop tour of these living reviews. So essentially, we're trying to take a behavioural science lens to identify barriers and enablers to COVID-19 vaccination acceptance and uptake. In line with the draft BESSI Principles 6, we're wanting to use these data to inform the design of BESSIs, and in particular BESSIs addressing the specific needs and concerns of certain groups. And this is just a hand wave, so we're planning future reviews that are focusing on the intervention piece, so just watch this space. And if you're wanting to find any more information, if you want to find these reviews or any other the resources that COVID produce, that's the link. So Ray, perhaps you could maybe pop that in the chat box for the participants, because there's a real range of resources there, not just focusing on vaccination acceptance, but all things COVID. So that might be a useful resource for people interested in this area. Thanks.
Wonderful. Thank you so much, Paul and Jake. And we have 25 minutes or so for some discussion. And I want to first address some of the questions that have come up specifically about what you've just heard. So maybe Kazi Rahman, if you're happy to unmute yourself, maybe ask your question directly, and then I'm going to come back to some people's contribution from the earlier round of insights, because I think some of them link up quite nicely to what we've just heard. I see Kazi has come online. Kazi, go ahead. And maybe introduce yourself so everyone knows where you're calling from.
Thank you, Marika. I'm Kazi Rahman. I'm calling from the north end of New South Wales. I'm working both in the health program here as well as in the academic environment. My question, thanks for inviting me to this session and giving me the opportunity to ask the question. So my question is to Jake about the beliefs about consequences of vaccination. So is it focusing on the efficacy of the vaccines or the adverse effects? And things are always changing on adverse events.
Yeah, exactly. So all of that will be captured. We decided to capture that all under beliefs about consequences. So there were 3 key belief, I guess, patterns in that, and one was related to perceived efficacy of the vaccine. So questioning kind of the speed of development and whether there'd been sufficient testing, which links into the second one, which is around safety. So risk of adverse events, side effects, that type of thing, and also linked into the third one, which is around perceived necessity. So one of the barriers that was coming up in terms of I feel in good health, or I'm relying on natural immunity, so I don't necessarily need to have something external put in my body. So those are the three kind of areas of barriers that we're capturing the beliefs about consequences around: efficacy, safety, and necessity. But there were a few other different angles that were taken there, but I would say they were the three main belief patterns. But beliefs and consequences was quite a well represented domain, and there's far more details in the report that you can pick out going into the importance of that domain in particular.
Thank you.
Great. Thank you, Kazi. Thank you, Jake. I wonder if we can bring James Smith and James Thomas and Helen Staff on to talk about their comments. And maybe James Smith, if I can go to you first, because there's an interesting point you made about, we've just heard about a multi-country study, but your question is about really the usefulness of that generalizability. And the reason why I've asked for James Thomas and also Helen Staff maybe to come on, because James Thomas, you've asked a very interesting point about the politics and culture, which of course is maybe I'm giving away my disciplinary bias here, but for me, politics and culture would be a different way of maybe describing different countries. To what extent really that angle has been explored, and Helen, your question links to that a bit. So I see that James Smith has arrived. James,
yeah,
could you tell us who you are and tell us your question? Thank you.
Absolutely, yeah. I'm James Smith. I'm a postdoc based in Oxford, although currently living in Marlborough, which is about an hour southwest of there in the UK. So my comment, it was a comment really more than a question. I've seen a few people mention that it would make sense to do studies across countries. But my impression is that with behavioral interventions, or BESSIs in general, as opposed to drugs, there's likely to be a lot more variation in their effectiveness depending on the specific context that the intervention is delivered in. And so I'm wondering if doing trials in many different places would really give us, there's not going to be a single overall effect of a BESSI. So should we instead be thinking about doing these locally? And I know that there are problems potentially with sample size, but perhaps in a pandemic, what you care about is what the best thing to do is at a particular moment in a particular context. And it's less about finding out what the true effect is of an intervention in general. So I'm just curious to hear people's thoughts on that.
Maybe we'll go to Susan first and then to Paul. There's two thoughts already.
Thanks. Yeah, I mean, this is such an important issue. And I think there's kind of two answers to it. One is that there are behavioural, environmental, social systems interventions that are shown to be effective and to have similar barriers and enablers across countries. So one example is the test, trace and isolate system, which is a cornerstone of pandemic control, has been done really well in many, many different countries, and really badly in some countries like UK, my own country. There's also a lot of generalities about the hesitancies about vaccination across very different countries. So I think one of the key things in building our knowledge about this area is to identify what are the principles and what are the findings that seem to generalize quite widely, and then what are the country-specific aspects in terms of culture and politics, and that's often in terms of people's beliefs and attitudes and many kind of behavioural patterns, but also the actual kind of social and material infrastructure of different countries. And that's going to be absolutely essential in terms of building on those general principles and understandings to specific interventions in different places. So I think multi-country studies are really important, I suppose, to identify exactly that. What are the things that are generalizable, and what are the dimensions that we need to think about when making things specific? I'm sure other people have got lots of thoughts on this really important question.
One of those
Yes,
people being Paul.
I absolutely agree with that, Susan. And so that is enabled by having a common methods section or a common template across multiple countries. And we'll probably never get a study that goes across 200 different countries. But if you can get 20 or so, then you might start to see what things are invariant across countries where you get a similar effect and which ones vary because of context, like, you know, sickness support or income support, which does vary a lot and will change things. But you require a common template to do that.
But I wonder, James Thomas, sorry.
Oh, sorry. I just was going to quickly respond to that, if that's okay.
Go
I think
ahead.
I agree with what you both have said. Just to push back on, I guess one potential downside for having a common protocol is that you might lose out on the ability to optimize based on kind of background knowledge about what you think is likely to be the best intervention in that particular place. If you have good reasons to think that for some reason a different type of mask will be better in a certain setting, sticking to a common protocol might mean that you find out more what the differences are between places, but that you don't end up actually with the best intervention for that particular place. So I think there might be a balance there, a little trade-off to think about.
Well, the common protocol can include co-creation and making sure that it's done with all the people in the particular setting that one's thinking about in terms of the intervention. So, you know, a common protocol can have massive variation within it. And I think that's one of the BESSI principles, is the importance of co-design and co-creation so that it is specific to localities.
Yeah, thank you. Thanks, James. Which I wanted to use to segue to the other James, because James, you had some thoughts on politics and culture and really how they interact with some of these interventions. From what you've heard now, do you have a sense of what exactly is missing or how that gap could be filled?
Yeah, I've got 2 points. One is that was the first thing that came into my head when you said everyone typed something all at once. So it wasn't the most prepared question I had. Just on the previous one, though, I think that's one of the useful concepts here is probably form and function. I think Diane Fangood's one of the people who talks about this quite a lot. And, you know, if you can have different forms of intervention components in different contexts, which actually then perform the same function. So one of the challenges when you're thinking about having interventions that work across different contexts is to actually think, well, okay, they don't have to look exactly the same, all of these different parts of the intervention. The point is whether or not they're sort of working in the same way. So it's the sort of the form of function thing. On my my question, it's nicely sort of linked to that, but I think we've got almost the same form of intervention across different countries. You know, we can talk about face coverings, as many of us have over the last year, and you know, the form and the function are much the same in different contexts, but the understandings and the meanings and the political meanings attached to that relatively simple device, I don't think any of us could have anticipated quite how political the wearing of a face covering could have got. But that is absolutely central to the effectiveness of that intervention in different places. And so, you know, I think, you know, that's one of the things which I think the pandemic's really revealed is the fact that how political public health actually is. I mean, public health is political, we know that, but I mean, the implementation of a relatively simple public health intervention is a highly political activity, and I don't know if that has been adequately researched, really.
Well, you're speaking after my own heart. James, sorry, could you just tell us quickly where you're calling from?
Oh, sorry. Yeah, I'm from the modestly named Epicenter, which is part of UCL in London.
Okay, fantastic. Thank you. And in a way, I want to hand over directly to Helen, because Helen, you offered yet another, maybe more granular perspective on the similar question. Do you want to share with the others?
Yeah, sure. Thank you. My name's Helen Staff, and I'm calling from well, I'm signing in from Leeds. I'm a postgraduate student at Leeds Beckett University. And so, yeah, I think, I suppose Susan kind of touched on it a little bit in terms of her response to the first James's question around sort of that generalization. And I think I was thinking around, I wrote attitude and personality types, but it's those behavioural patterns. And I just wondered, obviously, the different behavioural patterns and the way that we maybe would target them in terms of advertising and that kind of stuff, and whether any studies had started to explore that. I didn't know if I'd missed it potentially in the presentation that was provided around sort of the systematic reviews, but I was just wondering if we're starting to see some studies move away from that categorization and generalization around demographics and a culture, and this will work. So yeah, I think Susan kind of touched upon it earlier, but yeah, that was kind of just my thought to see it are we seeing this movement?
I have some thoughts on this. I don't know, Susan, if you want to come in because it was directed to you, but what I see in my discipline, which is much more the sociology, ethnographic based research, is yes, very slowly that argument is being made based on qualitative studies to say there are actually this demographic segmentation that we have used is really not applicable in countries that are hugely diverse, even from one village to the next, like South Sudan. And that means that community responses will be very, very different because communities are much smaller defined than the normal kind of demographic perspective would allow. So you see this, but it's very humble, and it's obviously methodologically completely differently. And it's very, very hard to generalize anything from that except the need to do it, right? So that it's a little bit of a circle in that sense. But Susan, I wonder what your thoughts are on that.
Nothing to add to that, yeah.
Thank you, Helen. So we have only 10 more minutes, and we did want to talk a little bit about next steps and future. And I did kind of give you an entry in the beginning to say we've had a couple of knockbacks lately, or a knockback really, in trying to have the BESSI collaboration active and going as strongly as we would like it to be. And I wonder, Susan, whether you want to talk about that a little bit, what we've seen and maybe our own lived experience of the very phenomenon that Paul just introduced to you, that there's really not that much funding attention on BESSI, and I think we've experienced this firsthand. So Susan, do you want to share some thoughts?
Yeah, bring some bad news, delighted to. Well, I think those of you who've been on previous webinars have heard us talking about bringing together a collaboration to try and get funding to set up a platform so that we could really support the bringing together of people and getting seed funding to get more research going. So we did get a group of people across different continents and put in for funding to the Wellcome Trust for a collaborative grant, and didn't get past the first stage. So we didn't even get past the screening, and I've been successful getting a collaborative grant for a different project and found Wellcome to be quite facilitative. So I have to say I was really surprised that we didn't get through to the second stage because we really put forward the arguments. We had a wide group of co-applicants representing different parts of BESSI and also Africa, as well as North America, UK, Australia represented. So share that with you, and it would be really helpful to get anybody's views about where you think we can go, as a group, and also what steps we should take. I mean, one of the things we were thinking about is, obviously we're a tiny group. We're just, doing the Twitter and the website and these webinars and trying to build a momentum behind this idea. But it strikes me that maybe we should move to a next stage where we find a group of people larger than ourselves that would be interested in activity, to bring in ideas, pairs of hands, energy to do more. And also a much wider group, really just of BESSI supporters. I don't know what we call everybody, but I'm wondering about, for example, putting a database on the website where everybody can just put who they are, where they're from, what domain they work in, research areas of interest. So we begin building a really big database of who's doing what and who's interested in what, across the world, because that could support all of us for going for funding, because that's what we'd like to do, is use this collaboration to support everyone to develop research in different ways. So really over to you, and I realize we've only got 8 minutes left. But we have got future webinars, so we can continue this conversation, because maybe we can start the next webinar with a summary of what people think. Maybe we can contact everybody after this, or you can contact us. Anyway, we'll think of a mechanism to get your ideas, bring them together, and make some progress. So in the time we've got left, yes, over to everybody for any ideas you have as to how we should go forward. Thanks.
Thank you, Susan. Yes, I think that what we will do in the next webinar is almost open it up in a slightly different format to workshop some of these ideas more. So we were thinking of moving from this webinar format where you have a panel and an audience to actually having a meeting, so that we can be a lot more interactive and exchange some of these ideas and make sure that the impressive momentum that we have doesn't get knocked back too much by this recent bad set of news. But we've had a couple of suggestions from the two Jameses on different funding sources. I wonder whether there are other thoughts, and I also wanted to go back to the kind of tragic misunderstanding, Atle, that we had from you when we all thought you said there's more international collaboration, and it turns out, no, you were asking for more international collaboration. I wonder, maybe Atle, a question specifically to you, whether you have information on whether the reason for this lack that you still see is rooted in the same reasons that we're experiencing, simply funders not maybe recognizing the importance of funding, or whether there are others. And while maybe you think about this, I'll hand to Jeremy. Jeremy, your thoughts.
Oh, sorry, I was putting my hand up to do after you've had that conversation with people on the call, Marika. So why don't we see if people have got comments? We don't have much time, and if there's space, I'll say something at the end.
Okay. So I see right now, unsurprisingly, we have a stunned silence, which is exactly the reaction that you saw us having when we got the rejection from the Wellcome Trust. But maybe this is actually a good moment to invite you to the next webinar, which is, we put these in very quick succession because we wanted to make sure that we have momentum going. And so next week is, okay, Atle, I saw you coming in, fantastic. Next week is an opportunity to have this conversation in more depth. Atle, what are your thoughts?
Yes, thanks. I'm not sure what the main barriers for international collaboration are. I must say that we're probably a little bit luckier in Norway than most of you are. We've been able to, funding has not been our perceived main barrier for two reasons. We're where I work at a state institute, we don't have to get funding. Well, there is some funding in the system. I mean, of course, to get $1 million for a trial, that takes some effort. But you know, hiring a couple of people for a few months, getting some equipment, we can do that within our current budgets. Maybe we're more comfortable positioned in the daily running of things. So our main barriers have been all the other ones: getting understanding, getting it done, getting the actual people working in infection control interested in evaluating the things that they're doing on the ground and that sort of thing. So for the international collaboration, I'm not sure people. I haven't done a great deal to make it happen because it's difficult to make things happen here, and it's so I don't know. And also, slightly related to that, I'm also a little bit concerned, and this is sort of a screwball from the side maybe, but a little bit concerned that we don't discuss the need for speed. The results are starting to come out as at least the West is getting vaccinated, more or less. And these things will definitely be, the results will be important for globally, I reckon, for a year or so. But still, we're running after the ball, and I'm definitely doing it. And too much emphasis on rigor in all that. There's a trade-off. I think the Bangladesh trial is an excellent example of the perfect trial, but it took a year. So there's something there to discuss, which goes sort of contrary to the basic scientific principles that we all agree upon. Sorry, I'll stop there.
Thank you, Atle. I want to hand over quickly to Jeremy before we wrap up. So Jeremy, now is your moment.
That was my moment. I'll try and be very quick. So I think one of the issues is I don't think we should just think about funding. We should also think about how we build community. and how do we actually start to get ourselves, there's a lot of things we can probably already do together that will be mutually supportive, that then will probably, if we build that community, help us be more successful with funding. So I think in future webinars, it'd be interesting to talk about that. How do we just start while we're still trying to get funding, and how do we sort of, we've been working as a very small NIDUS, but we need to grow that more broadly. So back to Marika.
Thank you, Jeremy. Well, one way we're trying to build this community is with the draft BESSI Principles. And we just want to end today's webinar with 2 invitations. One invitation I will repeat again to please join us again next week. But the second invitation comes from Paul and is particularly connected to the draft principles.
Yeah, thanks, Marika. So we've talked a lot about getting the community and the research going, but one of the other purposes of the BESSI collaboration was simply to raise awareness and to lobby funders and other groups to take the BESSI research more seriously. So one of the things we're looking to do is to get individuals and organisations to endorse the draft BESSI principles, and got some examples up here. If you're able to do that as an individual, or even better as an organisation, if you could email the email address there, bessi@bessi.net.au. And if it's an organisation, it would be great if you had permission to use the logo as well in that. And if you think of other organisations that we should be contacting, please let us know, or you could do that through the GIST mail list. And we can use that in our lobbying to other groups to say there's a whole lot of groups endorsing these principles. Thanks.
Thank you, Paul. Thank you so much, everyone, for joining. I promised you I will repeat the invitation for next week, and I'll do it so. You should have received an email from Lucas from the BESSI collaboration for next week's webinar, where we're going to go deeper into these questions of what community building activities are we able to do now. And I think, Atle, your point on speed is really well taken. We cannot afford in so many levels to lose the momentum that we have. And so we need to become creative in how we use this. So with this, I want to ask, thank you all again for joining. Thank you so much for the speakers. Thanks for sharing all your thoughts. And we really hope to see you back again next week. Thank you. Have a good day.
Bye.